Hello everyone and welcome back. So we are going to discuss the hypertensive disorders of pregnancy in this video. So hypertension is defined as change of blood pressure recorded on at least two separate occasions, and diastolic is 90 mm of Hg and systolic is 140 mm of Hg is called hypertension. We have the classification of hypertension as pregnancy induced hypertension, then chronic hypertension, and then the unclassified hypertension and proteinuria. The pregnancy-induced hypertension, hypertension and proteins developing after 20 weeks of gestation during the labor at purpurum in a previously non-hypertensive or non-proteinuric woman and reverts after purpurum. The PIH without proteinuria, the PIH with proteinuria, that is pre-eclampsia, and pregnancy-induced proteinuria without hypertension. Now we are having the chronic hypertension, which is known as which is also called pre-existing hypertension, and it is hypertension or proteinuria in pregnancy in a woman with chronic hypertension or renal diseases diagnosed either at pregnancy prior to 20 weeks of gestation or hypertension that does not revert after purpurum. The chronic hypertension without proteinuria, the chronic hypertension with proteinuria, and chronic hypertension with superimposed PE. Now we have the unclassified hypertension and proteinuria, which is sudden rise in BP with no previous history of hypertension. So there are three major classes of the hypertension. One is pregnancy induced, which is started in the pregnancy. One is chronic hypertension, which is pre-existing, and one is unclassified hypertension with proteinuria, which is sudden rise in BP. Now coming towards the pre-eclampsia. So we are having a scenario that there is a PG presented at 35 weeks gestation with the headache, history of headache, nausea and epigastric pain. Her BP is 160 by 100 and urine albumin is +2. So what is the diagnosis, the investigation, and when should we deliver and how should we deliver and what are the fetal complications and which drugs should be given? Another scenario is that there is a 24-year-old G2P1 present at 34 weeks gestation with headache, BP is 150 by 100 and urine albumin is +1. Edema feed is negative. And what is the diagnosis, the investigations and the fetal complications? Another scenario is that there is a PG 22 years old, 32 weeks pregnant, BP is 160 by 100 and edema albumin is present, and what will be the management options? So for pre-eclampsia, it is hypertension of at least 140 by 190 mm of Hg recorded at least on two separate occasions and at least 4 hours apart and in the presence of at least 300 mg protein in 24 hours. What is pre-eclampsia? It is the raise of BP in 150 by 90 and the presence of 300 mg protein in 24 hours. Now the collection of urine arising de novo after 20th week of pregnancy in previously normotensive woman and completely by 6 weeks, resolving completely by 6 weeks postpartum. So this is the pre-eclampsia when the hypertension is of 150 by 90 and it is recorded at two separate occasions, 4 hours apart, and the protein amount is 300 milligram and this protein amount completely resolved after the postpartum. So this is pre-eclampsia. Now the risk factors for preeclampsia are first pregnancy, that is nulliparity or primigravida, or conditions where the placenta is enlarged. Chronic hypertension, pre-existing vascular diseases, that is diabetes or autoimmunoscolitis, and chronic renal diseases, multiparous with 10 years or more since last baby. Extreme maternal age, that is less than 15 years or 40 years, BMI of 35 or more, antiphospholipid antibody syndrome, and family history of preeclampsia. The etiology or pathophysiology are that it is uterine vascular changes due to the ineffective trophoblasts. During normal pregnancy, cytotrophoblast invades the uterine spiral arteries, reaching the decidual segment and then the myometrial segment by 20 weeks. Almost invasion is associated with degeneration of the tunica media and replacement of fibrinoid matter, resulting in marked dilatation of the spiral arteries and increased intervenous blood flow. In contrast to the normal pregnancy, endovascular trophoblastic invasions remain superficial. As a result, the spiral arteries remain in muscular undilated and respond to vasomotor influences. There is loss of spirality of the spiral arteries. So there is loss of spirality of the spiral arteries and increase in peripheral resistance. The endothelial dysfunction is important in the modulation of vascular tone. When there is endothelial damage and endothelial dysfunction, it will lead to alteration in the production of certain vasoactive compounds, producing a vasoconstricted state. For instance, plasma prostacyclin, the predominant vasodilator, is decreased while placental production of the vasoconstricted thromboxane A2 is increased. Endothelial dysfunction may also lead to increased leakage of the fluid from intravascular compartment, leading to edema, proteinuria, and decreased colloid osmotic pressure. Endothelial dysfunction may also stimulate platelet and neutrophils activation, the activation of coagulation cascade leading to thrombus formation. The circulating factors. There is an evidence of the presence of certain factors in serum or plasma of women with PE which lead to endothelial dysfunction and increased neutrophils activation, for example, ROs and lipid peroxidation degradation products, cytokines like TNF and interleukin 6. The placental synthesis of oblastics and microvillus membrane. The complications of PE are mother, that is kidney, renal failure, proteinuria, and glomerulonephritis and oliguria. The liver complications, which are hepatocellular injury, subcapsular hematoma, periorbital necrosis, and HELP syndrome. The lung complications, which are ARDS, pulmonary edema, and pleural effusion. And the blood are DIC and thrombocytopenia. The eye are visual disturbances and retinal hemorrhage and detachment. The maternal death, generalized vasospasms. The brain are cerebral edema, stroke, and cerebral hemorrhage and eclampsias. The effects on the baby is polyhydramnios, IUGR, placental abruption, prematurity, intrauterine death, fetal growth retardation, abnormal fetal Doppler waveform, and fetal hypoxemia. Now, the clinical features of pre-eclampsia are symptoms and signs which are asymptomatic: frontal headache, visual disturbances, epigastric pain, and edema is present. The signs are elevated BP, fluid retention, epigastric tenderness, and hyperreflexia, and uterus, that is intrauterine growth resistation of the baby. The prevention is done by the use of aspirin and calcium supplementation and fish oil. The management is done is, first of all, history of the patient is taken, that is identify the risk factors and ask about the symptoms. Then ask if she is having hypertension already or she is on treatment for it. Then do the examination, that is record the BP, pulse, and exclude aortic coarctation and radiofemoral delay. Check for the edema and check thyroid and exclude thyrotoxicosis and Cushing syndrome. Examine the abdomen for epigastric tenderness and do neurological examination by assessing the reflexes. Do obstetrical examination, fetal heart sound auscultation presentation, and Liker volume. The specific investigations that are done for pre-eclampsia are baseline plus specific, that is FBC is done, which is emphasizes on falling platelet count and rising hematocrit. Thrombocytopenia is there. If platelet count is less than 50,000, then it is normal 1 to 3 lakh. If platelet count is decreased only, then do coagulation profile, that is PT and APPT. RFTs are done, that is serum uric acid level would be elevated in PE hyperuremia because decreased excretion of uric acid by kidneys. LFTs are done, that is transaminase, serum glucose phosphatase, and ALT elevated level present in PE level. And the urine RA is done for proteinuria, which is greater than 300 milligram. And dipstick urine analysis for proteinuria, which is 1 plus possible significant proteinuria, and if it is 2 plus and probable significant proteinuria. Protein creatinine ratio will be greater than 30 mg per mole, probable significant proteinuria. And to monitor the fetal complications, obstetrical ultrasound assessment is done for the fetal size, amniotic fluid volume, and placental position. If fetal compromise suspected on ultrasound, then biophysical profile for fetal well-being twice a week, and Doppler for the SD ratio, systolic diastolic ratio. Normal ratio is 3, and CTG is done. Now, the management of mild hypertension, that is 140/90, is do antenatal visits. When diastolic blood pressure is relatively normal, then proteinuria is mild. It may possible to monitor. Okay, if proteinuria is mild, that is 1 plus dipstick, then it may be possible to monitor the patient as outpatient. On each visit, history examination and fetal monitoring is done, and ask her to come or visit every 2 weeks. Then antihypertensive should be prescribed for such patients: methyl dopam 1 to 2 gram per day in 3 doses, and alpha and beta blockers, that is labetalol 300 milligram, and calcium channel blockers, that is nifedipine, and glyceryl trinitrates are given. Delivery: if BP is controlled and fetus is growing and no fetal compromise, and deliver her at the term. If the timing of delivery should be 37 weeks, she may go into spontaneous labor. And this is the management of the pre-eclampsia. So we have discussed the pre-eclampsia and okay, so first of all, we have discussed the scenario for it. We have discussed the types of hypertensions, which are pregnancy induced hypertension and hypertension of the unknown category. Pre-eclampsia, eclampsia. Okay. Pregnancy induced hypertension and unclassified hypertension and chronic hypertension. Then we have discussed specifically the pre-eclampsia. In pre-eclampsia, we have discussed the scenario that there is a PG present at 35 weeks gestation. So the diagnosis, the investigations, and when should we deliver, we should know about the hypertension. So we have discussed the preeclampsia, that it is a hypertension of at least 140 by 90 and 300 milligram protein in 24 hours. The risk factors are first pregnancy, and these are the risk factors. These are the etiological or pathological pathophysiology of the preeclampsia, which are uterine vascular changes and endothelial dysfunction and circulating factors. Then we have discussed the complications of preeclampsia, which are mother's complication, that is kidney, liver, and lung, and blood, eye, maternal death, generalized vasospasm, and brain, and the effects on the baby. Then the clinical features of preeclampsia, which are symptoms and signs, and how we will prevent it. Then we have discussed the management option, which is history taking and examination, and investigations, which are FBC and RFTs and LFTs, then urine RU for proteinuria, then dipstick urine analysis for proteinuria, protein creatinine ratio, and to monitor the fetal complications. In the next section, we will discuss about the eclampsia, and then we will discuss the gestational diabetes. Thanks for watching.